Hello everyone, hope you're all doing good. In this video, we are going to discuss about carcinoma cervix. So first, let us know how to come to a diagnosis of carcinoma cervix. That is your history and examination. Okay. So history will tell you the age group of the women will be mostly between 35 to 45 years. She will be a Paris woman. And there will be history of vaginal bleeding, like it can be an irregular bleeding, or she can complain of intermenstrual bleeding, or there can be postcoital bleeding, or even there can be postmenopausal bleeding. Okay. However, postcoital bleeding is the common presentation of carcinoma cervix, and postmenopausal bleeding is the common cause of CA uterus or CA endometrium. Clear? Right. Now, there can also be history of vaginal discharge, history of vaginal discharge that will be blood stained, and there can be offensive odor also. Okay, there can be offensive odor also. She can even complain of back pain or rectal pain, and there can be incontinence of urine and stool, loss of weight, as well as renal failure symptoms. On examination, there can be anemia, cachexia or edema, and on periabdominal examination, in advanced stages, you can even have hepatomegaly because of metastasis, and on perispeculum examination, the cervix will look hyperemic, and there can be erosions or ulcerations, and it will bleed on touch. Okay, and if there is a barrel shaped cervix, if you are able to see a barrel shaped cervix, then you have to think it is a endocervical carcinoma, right? Yes. Next we will do bimanual examination. While doing bimanual examination, what you will look for? You will look for the uterus size, position, mobility, and also any tumor or mass that is palpable. Usually in carcinoma cervix, the uterus will appear hard, fixed, and it will bleed on touch. Right? Then coming to perectal examination. On perectal examination, there will be involvement of rectal mucosa, so that can be checked, and induration of uterosacral ligaments can also be checked. You have to look for the parametrium involvement also. Okay. Yes. Then, now let's discuss about the risk factors of carcinoma cervix as such. Right. So, risk factors for carcinoma cervix. I have already told you it is HPV infection. Very good. So, HPV infection which will include 16, 18, 31, 33, 45, 52 and 58. Okay. Then HIV or chlamydia, as well as your human herb simplex virus 2. Okay. Then the risk is more when she had an early intercourse, that is less than 16 years, or she had a sexually transmitted disease including HIV. There is an early age at first pregnancy as well, or she is a multiparous woman. There is poor genital hygiene. She has multiple sexual partners. There is dietary deficiency of vitamins A, B, C, E, even folic acid. Of course, increasing age is also another factor. Oral pill usage, smoking and inadequate screening also. Clear? Right. Now let us discuss about the pathogenesis. Infection by HPV virus, especially the high risk types, that will include 16, 18. Okay, among this 16 is more common than 18. Okay, also 31, 33, 45, 52 and 58. Okay, so this is the reason for development of carcinoma cervix. So what happens? It will lead to the progression of precancerous lesion. Okay, the normal cell will be converted into a cell with a precancerous lesion that will be converted into a invasive carcinoma. Okay, now what happens when there is any risk factor? Okay, when there is any risk factor that will be associated with HPV infection, remember, in 6 to 12 months, about 80 to 90% of the lesions will go for spontaneous clearance, whereas the rest of the 10 to 20% of the infections will be persistent, and if it is associated with other risk factors, then there will be development of cervical intraepithelial neoplasia, and then it will be integrated into the cell DNA that will be leading for invasive cancer. Clear? Now what happens means, there are viral proteins E6 and E7. Okay, so the viral proteins E6 and E7 are mainly responsible for the initial changes in the epithelial cells. They will inactivate main tumor suppressor genes, namely P53 and retinoblastoma respectively. So E6 will inactivate the P53 tumor suppressor gene and E7 will inactivate the retinoblastoma tumor suppressor gene. Right? Now, inactivation of these gene host proteins will cause changes in the DNA repair mechanism. That is, there will be a disruption in this DNA repair mechanism, and also the process of apoptosis will be affected. Okay. Not only this, there will also be multiple genes that are involved in DNA repair, cellular proliferation, growth factor activity, mitosis as well as angiogenesis. If you see, these are all features of CA cervix, any carcinoma, right? So, this will become increasingly expressed both in CAN as well as CA cervix. Okay. Now, let's discuss about some of the relevant anatomy as well. Okay. Before understanding the further concepts, we have to revise the relevant anatomy related to CA cervix. Okay. So, relevant anatomy here. We know cervix is the lower part of uterus, right? It is the lower part of uterus and it is cylindrical in shape and it is connected with the vagina through the endo-cervical canal. Yes? Now, what you have to know is, we have the endo-cervix which is lined by columnar epithelium, right? Also, we have the ectocervix which is lined by stratified squamous epithelium. Now, a junction between these two is known as SCJ, that is squamo-columnar junction. Squamo-columnar junction. Now, usually this squamo-columnar junction will be lying over the endo-cervical canal. But there are so many changes that is happening in the cervix during pregnancy as well as early adolescence, right? So, what happens during this period, the squamo-columnar junction, say this is the cervix, okay, the squamo-columnar junction which is endocervical now, okay, it will come to lie over the ectocervix. Okay, so let us take its first place as original squamo-columnar junction and this is the new squamo-columnar junction. So, the transition zone is nothing but the space between these two regions. This is transition zone. Okay, but soon after menopause or during late reproductive years, what happens? This can even go again into endocervical position. So, finally, during menopause, the squamo-columnar junction is going to lie in the endocervical canal. Can you understand? Yes. So, there is a transition of squamo-columnar junction. It is not going to remain stagnant. That is what I want you to understand, right? Yes. Also know about lymphatic drainage. So, the lymphatic channels principally passes into the parametrial and paracervical lymph nodes, and from there it will be passing to the internal, external and even the common iliac lymph nodes, and finally this will go to the para-aortic lymph nodes. Okay. Now, let us discuss how to diagnose CA cervix. Okay. So, diagnosis of CA cervix. If you see any suspicious lesion, then you can take pap smear, and if pap smear is abnormal, then you can offer her colposcopy or even colposcopy with biopsy or a direct punch biopsy also. Okay. Remember, the biopsy should be taken at the edge of the growth, that will be including the surrounding normal area also. Clear? And then If you suspect endocervical cancer, offer her endocervical curettage as well. Okay. What are the other investigations we can do? We can offer CBC, urine analysis, liver function test, kidney function test, and even other radiological investigations like chest X-ray, IVP, CT scan, MRI, or even PET scan can be needed. Clear? Right. Now, let's see the advantages of CT and MRI in the patient. Okay. With CT, we'll be able to make out lymph node involvement or if there is any distant metastasis. And with the MRI, we'll be able to check the tumor size, tumor extension, also the parametrial involvement. Clear? Right. Now we are going into the most important part, that is staging of CA cervix. Okay. So here we have stage 1 where the carcinoma is strictly confined to the cervix. Okay, even the extension to the corpus is disregarded here. Okay. Now we have two subdivisions here. One is stage 1A, which means it is an invasive carcinoma that can be defined only by microscopy, and maximum invasion it can have will be up to 5 mm. That is, the lesions will be less than 5 mm only. Okay. This is further divided into 1A1 and 1A2 where the stromal involvement will be less than 3 mm in depth, or 1A2 which is 3 to 5 mm in. Clear? Now let's see 1B. Here the invasive carcinoma will have a depth more than 5 mm and the lesion will be still confined to the cervix uterus. Okay, cervix of uterus, right? So this is further divided into 1B1 where the invasive carcinoma depth of invasion is more than 5 mm plus the size, okay, size of the lesion will be less than 2 cm in greatest dimension. The same way in 1B2 the size will be between 2 to 4 cm in greatest dimension, and in 1B3 the lesion will have a size more than 4 cm, and in 1B3 the lesion will have size more than 4 cm. So this is of significance. This is somewhat big tumor, right? Yes. Now let's see what is stage 2 carcinoma. Stage 2 carcinoma means the carcinoma invades beyond the uterus. Okay, invades beyond the uterus. Okay, but it has not extended into the lower third of vagina or the pelvic side wall. Okay, so these areas are not involved. Okay, so this is further divided into 2A where the involvement of carcinoma is limited only to the upper 2/3 of vagina, but there is no parametrial involvement. Okay, this is further divided into 2A1 and 2A2 The invasive carcinoma will be less than 4 cm in 2A1 and it will be more than 4 cm in greatest dimension in 2A2. Coming to 2B, there is parametrial involvement, but it is not reaching the pelvic side walls. Okay, so that is 2B. Now let's talk about stage 3. So stage 3 means the carcinoma is now extending into the lower third of vagina or extends up to the pelvic side wall, or it may even cause, while crossing, it may involve the ureter also. So there can be hydronephrosis or non-functioning kidney, and there can be involvement of nodes also, including your pelvic and para-aortic nodes. Okay, so this is classified into 3A, where the involvement is seen in the lower third of vagina, but there is no extension to the pelvic side wall. Okay, then 3B, where the extension to the pelvic side wall is seen with hydronephrosis or a non-functioning kidney due to tumor. Okay, then 3C means there is involvement of the nodes irrespective of the size and extent of the tumor. Okay, if there is nodal involvement, you are not going to check the size of the tumor. Okay, so this is irrespective of the size and extent of tumor. So this is divided into 3C1, where there is metastasis in the pelvic lymph node only, and 3C2, where the para-aortic lymph nodes are involved. Clear? Now coming to stage 4. Here the carcinoma has extended beyond the true pelvis or it has involved the mucosa of the adjacent organs like mucosa of the bladder, rectum. Okay, so it is further divided into 4A, which is spread of growth to the adjacent organs, and 4B, which is spread to distant organs. Okay, yes. Now this image will help you in learning about the staging of carcinoma cervix. So first one is a microscopic carcinoma only, and the second one it becomes macroscopic carcinoma, and that is 1A, it is microscopic carcinoma only, and in 1B it becomes a macroscopic carcinoma, right? You are able to see it here, the lesion is visible only in microscopic lesions. And then what happens in 1B2, the carcinoma is between somewhat 2 to 4 cm in size, right? And in 1B3 what happens, it becomes more than 4 cm in size, right? So that is not shown here, but yeah, it is 1B3 I guess, yeah. Okay, and what happens in second stage, there is involvement of the vagina and parametrium, but there is no involvement of the lower 1/3 of the vagina or the pelvic side wall. So it involves the upper third of the vagina, as well as in 2B there is involvement of the parametrium. And in 3A, it is also extending into the lower third of the vagina, and in 3B, it is crossing and going to the pelvic side wall, where it can even involve the ureter. So at 3B stage, there can be hydronephrosis as well as a non-functioning kidney as well. Okay. Then we also have a 3C now, which is going to talk about the pelvic lymph nodes, as I told you, which is not mentioned here. 3C1 is pelvic lymph nodes and 3C2 is para-aortic lymph nodes, right? And this is 4A, which is involving the adjacent organs, and which is 4B, which will be involving the distant organs as well. Clear? So this is all about staging of carcinoma cervix. Now let's see about the management. For this, I am going to classify the carcinoma cervix into early stage carcinoma and advanced stage carcinoma according to the staging. So the early stage lesions will include stage 1A, stage B1, stage B2, and then stage 2A1. And next is advanced stage. Here the lesions will be B3 and 2A2 and other higher stages. Okay. So what you have to keep in mind is all these lesions are less than 4 centimeter. Okay. And all these lesions are more than 4 centimeter or involving the distant side from the cervix, okay, including the lower third of vagina or parametrium, pelvic side walls, whatever it is, right? Yes. Now let's discuss about the pathology of carcinoma cervix. So pathology of carcinoma cervix. First, let us speak about the microscopic lesions. In 80% of the cases, the microscopic lesions are seen in ectocervix. These are hypertrophic lesions, exophytic lesions as well, which have characteristic cauliflower-like growth, and there can be erosions or ulcerations as well. Okay. Then in the remaining 20% of the cases, it is seen in endocervix, which is a barrier shaped cervix that will be widened, but it may look healthy also. Okay, right. Now let's talk about the microscopic types of CA cervix. Squamous cell carcinoma is the most common type of CA cervix, which will constitute about 70% of the cases. That will include keratinizing and non-keratinizing as well as papillary type. Okay. Then we also have the adenocarcinoma, which will constitute about 25% of the cases. We also have other types of CA cervix. Miscellaneous types may include mucinous endocervical carcinoma or serous small cell type, phyloglandular type, adenoid cystic, and even adenosquamous. Okay. Now let's see about the spread of CA cervix. Okay. Spread of CA cervix. So direct spread can happen to the vagina, uterus, parametrium, urinary bladder, Also the rectum. Rectal involvement is however less common. Okay. Then there can be lymphatic spread as well. As we have seen, lymph nodes that can be involved include the draining lymph nodes like cervical or parametrial lymph nodes, your obturator lymph nodes. It can involve your internal iliac, external iliac, or even your common iliac lymph nodes. And finally, para-aortic lymph nodes can also be involved. Okay. Next spread is hematogenous spread. Okay. So hematogenous spread can occur to lung, liver, bones, brain, even ovary and kidney. Okay. One important thing we have to discuss is lymphovascular space invasion. So, it is nothing but the tumor invading into the blood vessels as well as the lymphatic channels, and when this is involved, there will be definitely a poor prognosis. Okay. Now let's discuss about the complications of carcinoma cervix. Complications of carcinoma cervix. First and foremost complication that can even lead to death is uremia. Okay, because of ureter obstruction. There can be hydronephrosis or pyometra, vesicovaginal fistula, or even a rectovaginal fistula can also be seen. Okay. Now let's discuss about the differential diagnosis. Differential diagnosis will include cervical polyp. See, we know a polyp is a red pedunculated mass, right? A polyp will look like a red pedunculated mass that is arising from the cervix, and it may come out through the os also. Okay. Second one, a polyp usually does not bleed on touch. The mass is not friable, and for final diagnosis, you will do a biopsy. This can be given as a clinical question also. Okay, they will show a cervical polyp, they will give a history like she has bleeding, she is a postmenopausal woman, and she has now came with bleeding complaints, and we have examined the patient and found this lesion. Okay, they may ask you whether it is a cervical polyp, and they may give a one hinging word like it does not bleed on touch. Okay, so what you will select? You have to select cervical polyp. Definitely in exams, don't ever think the image will be they will make it very clear like it is cervical polyp. Okay, even ulcerated polyp also they can give, and there can arise a confusion if it is a carcinoma cervix or a polyp. Okay, so in that case we have to go to the clinching word, it does not bleed on touch. And sometimes they may even ask, what will you do for confirmation of your diagnosis? What will you do? Biopsy. Clear? Next one is cervical erosion. This is also a red, velvety appearing lesion, and definitely this is not indurated, does not bleed on touch, but oozing may be present. Okay. And the next lesion is cervical tuberculosis. Okay. Cervical tuberculosis. How a tuberculotic ulcer will look like? It will look mostly like an erosion. Yes. And on histology, it will definitely show a granulomatous lesion that will be having giant cells with or without caseation. Okay, in the presence of acid-fast bacilli or smear from cervix, and even you can go for a culture of the specimen also, right? Yes, and don't ever forget a cervical syphilitic ulcer also in diagnosis. So this lesion will look like it will have an everted now this ulcer will be a punched out ulcer with an indurated base. Again, you will go for biopsy for confirmation of the diagnosis, right? Now, let's go into the management in detail. But before starting that, I have to tell you one thing. So, management means in early stage, that is, I mentioned stages 1 to 2A except 1B3, right? Except 1B3, you will offer surgery plus radiotherapy. Okay. Now, in advanced stages, okay. So, what are the advanced stages I told you? That is 1B3 and the next stage, that is 2B till 4. These stages will be treated by, yes, very good, it will be treated by chemoradiation, right? Now, let me tell you stage wise treatment, okay, so that there will be no confusion at all. So, for stage 1A1 and there is no lymphovascular space invasion, you will offer conization or even a simple hysterectomy. I am writing it as CSH if family is complete. Okay, make sure the family is complete. Clear? And the next stage, that is 1A1 only, but there is lymphovascular space invasion. So, what will you offer? You will offer is conization can be offered again, or radical trachelectomy can be offered, or even you can offer modified radical hysterectomy, that is MRH, if her family is complete. Clear? And the next stage is stage 1A2. Here also the same thing, you will offer either conization or radical trachelectomy, okay, and radical trachelectomy or modified radical hysterectomy if the family is completed. Clear? Next stage is 1B1. Here we will offer radical trachelectomy, okay, it is radical trachelectomy, not radiotherapy. Please remember, it is radical trachelectomy. And radical hysterectomy if family is completed. And for stage 1B2 or 2A1, you will offer radical hysterectomy or chemoradiation. For the next stage, that is stage 1B3 and 2A2. These are the carcinomas which are having more than 4 cm mass lesion, right? So, in these tumors, you will offer again chemoradiation only. Then for the next stages, that is stage 2B to 4A, you will offer chemoradiation again. And for stage 4B, okay, which is the most advanced stage, you will offer all palliative treatments, that is palliative radiotherapy, chemotherapy or supportive care. Okay, right. Now, you can offer pelvic lymphadenectomy also, even in the early stages, okay, that is 1A1 when there is lymphovascular space invasion and up to 1B2 or 2A1. Clear? Right. So, let's discuss about the types of hysterectomy here so that you will be having a clear idea of what I have mentioned as simple hysterectomy, radical hysterectomy, modified radical hysterectomy and all. We have to know the name and we have to know what we are doing to the parametrium and paracolpos in each procedure, followed by how vagina is removed or not, or what part of vagina we are removing, and where we are ligating the uterine vessels. That is also important, as well as where you are cutting the uterosacral ligament is also very important. So, the first type is a simple hysterectomy or extrafacial hysterectomy. It is also known as extrafacial hysterectomy. Here, with the name itself tells we are not going to do anything. Okay, the parametrium paracolpos is going to remain. It is not going to be removed. Vagina is also not going to be removed, and the uterine vessels will be ligated as the isthmus of the uterus itself, and uterosacral ligament will be cut at the junction of the uterus. So, only simply removing the uterus and the ovaries is simple hysterectomy. Clear? And the next type is modified radical hysterectomy. Here, of course, we will be touching all of the other components also. So, here we will be removing the parametrium and paracolpos, that is medial to the ureter. We are not crossing the ureter, which is medial to the ureter we are removing, and upper vagina is removed. Only 1 to 2 centimeter of vagina is removed, and the uterine vessels are ligated at the point of crossing of the ureter. We are not crossing the ureter, that is important. Okay, and in the uterosacral ligament will be cut near the rectum. And the third type is radical hysterectomy. In radical hysterectomy, the entire parametrium will be removed and upper third of vagina will be removed. That means it will be crossing more than 2 centimeter of vagina. Upper part of vagina will be removed, and the uterine vessels will be ligated from its origin from the internal iliac artery, and again here the uterosacral ligament will be cut near the rectum, right? And the fourth type is extended radical hysterectomy. Extended radical means we are going to extend radically, we are trying to remove all the possible areas of occurrence of carcinoma cervix or any other lesion. Okay. So, here the entire parametrium will be removed as seen above, and here almost 3/4 of vagina is removed, and the uterine arteries are ligated from the origin of the internal iliac artery, and there is ligation of the superior vesical artery as well, and the uterine sacrals are cut near the rectum. Okay, and for partial exentration procedure, the entire parametrium will be removed and the uterosacrals will be cut near the rectum. And you have to know that upper 3/4 of the vagina, the terminal ureter, and even a segment of a bladder or even the rectum will be removed in partial exentration. Clear? And the uterine vessels will be ligated at the origin from the internal iliac artery, and you will be ligating the superior vesical artery. So, what you have to understand is the important point that is making the difference here is the upper third of the vagina, right? So, this is the upper third of vagina, terminal ureter, and a segment of the bladder or rectum is removed. That is partial exentration, right? Yes. Now, coming to discuss about the various procedures we have learned. So, what is radical trachelectomy? Radical trachelectomy is a fertility preserving surgery. So, when the woman is desire for fertility and size of growth is less than 2 centimeter, then there is no pelvic metastasis, we will offer this procedure. Okay, so how will we do this procedure? There will be 80% removal of cervix, upper vagina, and there will be transection of Meccan Rodets ligament as well. That will be done bilaterally. And if we do radical trachelectomy, the chance of pregnancy is going to be 30 to 40%, and remember to deliver them only by cesarean section. However, this is not a permanent solution. There can be recurrence risk also with this procedure, that can be about 5% recurrence. Okay. Now let's discuss about the complications of surgery. So complications of surgery. Okay, any surgery if you offer, there can be anesthetic complications, or the mortality can be due to the surgery itself. So surgical mortality can be 1%. Definitely there can be hemorrhage or paralytic ileus or bowel obstruction. Okay, all these are seen in 1% of the cases. And then thromboembolism, pulmonary embolism is also seen in 1 to 2% of the cases. Finally, urinary tract fistulas can form because of injury to the ureter and adjacent organs. So the types of fistulas can be uterovaginal fistula, ureterovaginal fistula, that is about 1 to 2% chance, and even vesicovaginal fistula, that can also have a chance of 1 to 2%, and finally even strictures can be there. Okay, there can be voiding dysfunction also when due to surgery, that will include atony of bladder and the chance of infection, sepsis, and febrile morbidity also increases. Late complications will include your lymph cyst formation, that is 5% chance of lymphedema also. Clear? Right. Now let's discuss about radiotherapy. So radiotherapy, both teletherapy, that is external beam radiation, that is the radiation given from a distant site, as well as brachytherapy. Brachytherapy means there is a point of contact with the organ to be treated. Okay, brachytherapy, that is intracavitary brachytherapy, is also possible here. Okay, for teletherapy we'll be using iridium 92, and for brachytherapy we'll be mostly using cesium. Okay, here you have 2 points of reference which is important. So point A is 2 cm above lateral fornix and 2 cm lateral from uterine canal. Okay, here the radiation you will give is about 7000 to 8000 centigrades. Okay, point B is almost similar, but it is 3 cm lateral to point E, that is. Okay, so it is 3 cm lateral to point E, that's it. Okay, and here we will give a radiation dose of 6000 centigrade. Okay, and lymph nodal teletherapy can also be given. So if suspected involvement of pelvic lymph nodes, it will be changed into a pelvic field radiation therapy. Okay, so brachytherapy or teletherapy will be there, but apart from that, you have to give pelvic field radiation also. Pelvic field, entire pelvic field should also be covered, right? Yes. Now, what are the advantages of giving radiotherapy? It decreases the tumor volume and it reduces the anatomic distortion that is caused by the cancer, right? Now, what are the contraindications? Contraindications of giving radiotherapy will include pelvic inflammatory disease, myoma, your ovarian tumors, etc. Okay. Now, what are the complications? This is very important, right? So, when you give radiotherapy, there are also so many complications you will face that will include anemia, diarrhea, proctitis, rectal stricture, ovarian failure, pyometra, radiation fibrosis can also occur, especially in the bowel and bladder. There can be intestinal as well as urinary strictures as well as fistulas, as we have discussed. And most important thing can happen is skin burns. Yes, that is also possible. There can be avascular necrosis of femoral head when it is given as a brachytherapy. There will be irreversible atrophy and stenosis of vagina that will occur frequently with radiation only. Okay, and it may also lead to sexual dysfunction, right? Yes. Now, let's discuss about chemotherapy in cancer cervix. Chemotherapy, usually we give a single agent. Important drug, cisplatin. Okay, that will be given at a dose of 40 milligram per meter square weekly, and this can even be given as chemoradiotherapy when it is combined with radiotherapy, and it will be given up to 4 to 6 courses that will improve the radiation effect, because cisplatin is going to improve the radiation effect also. And in some cases, instead of cisplatin, you can even give carboplatin as well. Okay, because carboplatin is somewhat less toxic when compared to cisplatin. Okay, and then how will you follow up? Okay, so follow up after treatment, you have to follow up every 3 to 4 months in the first 2 to 3 years. Okay, suppose if recurrence occurs within these 3 years, means then 6 monthly follow up should be done up to 15 years, then annually for lifelong. Clear? And then in case of ureter preserving surgery, suppose if you have done a ureter preserving surgery, then you have to take pap smear 3 monthly once for 2 years and 6 monthly then up to next 3 years. Okay, when you did a conservative surgery, that is, you have preserved the uterus means. Okay, now how will be the prognosis of CA cervix? See, the overall 5-year survival rate of CA cervix is going to be 75%. Okay, roughly for CA uterus, this is going to be about 85%, and for CA ovary of the epithelial cancer, this will be very bad. Okay, comparingly, CA uterus is having a better survival rate, and the worst prognosis is seen with CA ovary. Okay, now if you take the 5-year survival rate according to the stage 1A has a 100% survival rate, stage 1B has 90%, stage 2A has 70% survival rate, and stage 2B has 45% survival rate, stage 3 has 15 to 40%, and finally stage 4A has 15 to 35% survival rate. Okay, so I hope you would have understood CA cervix. We have dealt in detail about what is the etiology, the relevant anatomy, lymph node drainage, various stages, and how to classify macro and microcarcinoma, as well as we have dealt in detail about the treatment modality and the treatment side effects and how you have to follow up also. I hope this video would have been helpful to you. So until we meet at the next video, keep going, happy learning, take care, and bye bye.